Welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I am your host, Chris Paine, the editor for MS Focus. I'm joined today by Dr. Ben Thrower, who will be sharing some valuable information regarding Can I Ever Stop My MS Therapy? After his presentation, we'll open it up for your questions and comments. Now I'm delighted to introduce our speaker. Dr. Thrower is the medical director of the Andrew C. Carlos MS Institute at the Shepherd Center in Atlanta. We're proud to say that he's also the senior medical advisor for the Multiple Sclerosis Foundation. We're pleased to have him join us this afternoon. Dr. Thrower, thank you for being here with us. And now I turn it over to you.
Great. Thank you. And thank you to everyone who's joining us here. So I'm going to see if technology will cooperate and we'll pull up our presentation. Get my glasses on so I hit the right buttons. All right. So there are a lot of hot topics in the MS world right now. And I would say the concept of aging and can I stop my therapy at some point are certainly amongst the topics of great interest at this point. So this is we're sort of going to look at what aging does in the human immune system, what that means for the person living with multiple sclerosis, and then what that means in regards to potentially stopping your disease modifying therapies. And how do we measure how you're doing with your MS? We'll talk about some new technologies out there that give us insights into what's going on with a person's multiple sclerosis. So between 35 and 50% of people living with multiple sclerosis are over the age of 55. As we age, we know from the big picture standpoint that people with multiple sclerosis tend to have fewer relapses. They tend to have fewer new lesions on MRI, but in some people, there is a slow progression of disability. And that's a fairly common thing that we see in the exam room. We're in the exam room talking to the person with MS, and what we frequently see is the person is not having relapses. Their MRI is stable, and that's all good news. But then the person says, yeah, but I feel like I'm slowly getting worse. And I think one of the things that we want people listening today and in the future when this is recorded is we believe you. We know that that happens. We know that you can get worse in spite of having a stable MRI and no relapses. The term for that has come out in the past few years is PIRA, P-I-R-A, progression independent from relapse activity. And this is defined as worsening of disability when there are no relapses and no new lesions on MRI. So what is it that drives progression independent of relapse activity? We know it's a common scenario, but how it works in one person with MS may be different from how it works in someone else with MS. We're coming to understand that there are different types of inflammation. There's this concept of compartmentalized CNS inflammation, or these little sort of nests, if you will, of B cells that set up shop in the brain and spinal cord. They tend to set up shop in the covering of the brain or the meninges. There is a lot of interest in a type of cell in the central nervous system called microglial cells. Typically, microglial cells are good things. They are cells that go in and clean up damage in the central nervous system. It looks like in some people with multiple sclerosis, those microglial cells can take on a new role, and a new role that may not be good, and that's that they may drive low-level inflammation. We think neurodegeneration or cell death can be part of what drives PIRA. Loss of compensatory mechanisms or neural reserve may drive PIRA. So our brain has a certain ability to adapt to injuries. And if you think of MS lesions as little injuries in the brain, there's a certain capability of the central nervous system to adapt to that injury. As we get older, we lose some of those compensatory mechanisms or neural reserve. So over time, that MS lesion that maybe years ago was giving you this much trouble may now give you this much trouble, The lesion didn't change. The brain's ability to adapt to that lesion is what changed. And then deconditioning, we can't discount that. It's been estimated that probably only 15% of Americans get the amount of exercise that we should be getting. And that number may be higher in the MS community. So that lack of exercise and becoming more sedentary could be part of what's driving this loss of function in some people with MS. So disease-modifying therapies, and this applies to all disease-modifying therapies that we currently use in multiple sclerosis, tend to target inflammation outside of the brain and spinal cord for the most part. With aging, that sort of inflammation that's driven from outside of the brain and spinal cord tends to maybe become less. We mentioned that compartmentalized inflammation through B cells in the brain and those microglial cells. So that type of inflammation that's more in the brain may become more important than the inflammation that's being driven from outside of the central nervous system. MS disease modifying therapies may become less effective as we age. The risk of side effects, especially with our highly effective disease modifying therapies, may increase with age. So at some point, that risk benefit ratio may switch from having a net positive effect from the disease modifying therapy to maybe actually having more risk than benefit as the person with MS ages. So as we age, there is this concept that the immune system changes, and that the word for that is immunosenescence. And so what happens is that there are changes in both the innate and adaptive immune system. The innate immune system is what you're born with. The adaptive immune system is what you learn to how your immune system evolves as we age, as we grow up. So there is a decrease in production of new immune cells, there's impaired function of immune cells, and the chemical messengers that our immune system uses tend to change. There's a term that has come about in the past few years in the immunology world called inflammaging, or a change in the immune system as we age, so that we're not able to generate big inflammation, but what it's replaced with is a low level of chronic inflammation as we age. So as we get older, is all of that put together overall, is that a good thing for people with multiple sclerosis, or is it a bad thing for people with multiple sclerosis? I would say it's going to vary a lot from person to person, just like your MS story, how your MS has behaved over years varies tremendously from one individual to the next. How that immune system aging affects your MS may vary from one person to another. If we look at the decrease in relapses and the decrease in new lesions on MRI, well, those are good things. It's great that you're not having relapses or new lesions on MRI. If a person with MS now has this chronic low-level inflammation and they're seeing progression of disability, well, those are not good things. So the million-dollar question, can I stop my disease-modifying therapy? We're going to talk about the risks and benefits. We're going to talk about studies that have looked specifically at this question. And then importantly, how do I measure how my MS is doing? If with aging, I can't really count on relapses or new lesions on MRI, those are very obvious things. If that's not what I'm going to be looking for, I'm more looking for progression of disability. Are there other biomarkers that I can use to tell me what's going on with my multiple sclerosis? So I would say that when we think about stopping therapy, we really should probably divide that into the concept of truly stopping, discontinuation, versus the concept of de-escalation. So discontinuation is obviously stopping your treatment. How people with MS feel about stopping their treatment does vary quite a bit. And we see this every day in our MS center. We have conversations with individuals who might be appropriate for stopping their disease modifying therapy. And one person may say, absolutely, I would love to do that. And the other person would say, I don't know, it makes me a little bit nervous. I'm going to lose sleep at night worrying about this. In this NARCOMS study in the first bullet, really spoke to that. What they found in this NARCOMS study is that 36% of people living with MS would be very unlikely or at least unlikely to stop their therapy. And these were older individuals. So maybe in some people, the discussion is not stopping, but it's de-escalating. De-escalating might mean switching to a therapy with a lower risk, or it might mean modifying the dose of a treatment that you're on. We'll talk about some research that looked at some of the de-escalation strategies. So there are three studies that we want to take a look at that specifically looked at stopping treatment. There was one called DISCO-MS, there was a DOT-MS study, and then there was a large French registry called OFFCET that looked at what happened when people went off of their treatment. So DISCO-MS specifically looked at older individuals. So these folks were 55 years of age and up. They could have any type of multiple sclerosis. To get into the study, your MS had to be stable. And the way they defined stable was that you could have no new lesions on your MRI for the past 3 years and no clinical relapses for the past 5 years. These folks were, with their permission, randomized to either stay on their treatment or go off of their treatment. This was not a blinded trial on the part of the people living with MS. They obviously knew if they were on or off of their treatment. The evaluators were blinded. So the people reading the MRIs, the people taking the histories, looking for relapses, doing the neurological examinations were blinded. They didn't know if people were on or off treatment. Most of these people were on older platform therapies. So 75% of these individuals were on either a beta interferon or glutamer acetate. So what did that study show? So what in the big picture, what it showed that most people stayed stable. So 90% of people in both groups had stable MRIs. They did not have relapses. They didn't have progression of disability. But there were some slight differences between the two groups. Clinical attacks or relapses were seen in about 2.3% of the group that went off of treatment, as opposed to 0.8% of the people who stayed on treatment. The group who went off treatment, about 10.7%, nearly 11%, had some new lesions on MRI versus 3.9% of the people that stayed on treatment. I think one of the important take-home messages from this is that there were no differences in disability progression, quality of life, or cognitive testing between the two groups. So what's the take-home message from that? So what I tell folks is that in people over age 55 who've been stable, no relapses, no new MRI lesions recently, that stopping one of the older disease-modifying therapies, interferons or glutamer acetate, was associated with a very low risk for new MS clinical activity. So even though there was a difference in the MRI activity between the group that stayed on and the group that went off of treatment, those new MRI lesions did not seem to be associated with progression of disability. And when we are having this discussion about stopping treatment, I don't think there's ever been a greater example of where shared medical decision making really comes into play. So this is, I think, a situation where your MS healthcare team should really be serving as a guidance counselor to you. So we should be putting all of this information in front of you and then letting you make an informed decision. I don't think this is always a situation where there's a clear right or wrong. Your individual comfort level, your psychology, is going to play a role. I think for some people, the hassle of being on a medication, the financial cost of the medication, your family's wishes. I've had numerous situations where the person with MS was inclined to stop their treatment, but their spouse or maybe their family members were pretty nervous about it. And in the end, that it was really a family decision, and people ended up staying on treatment really but to make the whole family happy. So the DOT-MS study was a little bit different. So this was age 18 and up. You had to have been stable both with MRI and clinically for at least 5 years. And these people were on one of the older disease-modifying therapies like interferons or glutamer. There were also some people on oral treatment, dimethyl fumarate or teriflunomide. So you could argue that this group is like the DISCO-MS. These are primarily not people on newer, highly effective therapies. So these are typically not people on B-cell therapies or natalizumab tisabri. This was a younger group of people. These people average, their median age was 54 versus age 63 for the DISCO-MS trial. What did this study show? So the people that stopped, went off of treatment, they ended up stopping the study a little early because there were more relapses in the group of people that stopped their treatment. Still, the numbers were low. So 8 of 45 in the people that stopped treatment had new lesions on MRI, and 2 of them had clinical relapses. None of the folks that stayed on treatment had any relapses or new lesions on MRI. So in this group of people that were younger than the DISCO-MS study, there did seem to be a small risk in stopping your platform disease modifying therapy. And then finally, this very large French registry looked retrospectively at what happened when people over the age of 50 stopped one of the highly effective therapies. And so the highly effective therapies that were looked at in this retrospective trial were fingolimod or Gilenya, natalizumab, tisabri, or one of the anti-CD20 agents that were available at that time. So at that time, it would have been either rituximab or ocrelizumab. At the time the study was done, Kesimpta and Briumvi were not available. So what they found is that in the group that stopped either fingolimod or natalizumab, there was a higher risk of MS relapses. In the group that stopped one of the B-cell therapies, ocrelizumab or rituximab, they did not see any increase in relapses. And this may, to some degree, speak to the mechanism of action of these drugs. There is some evidence now that the B-cell therapies may have a lingering protective effect after the drug is discontinued, whereas fingolimod and natalizumab, as effective as they are, that effectiveness seems to disappear, and there may be even some risk of a rebound or a higher risk of relapse in that period after the drug is discontinued. So what are some of if we don't want to stop treatment, what are some of the de-escalation strategies? So if you're on a highly effective therapy like a natalizumab or an ocrelizumab, how might we modify that if we're moving you towards getting off of it, but we don't want to just stop it outright? So there are studies looking at extended interval dosing with both of these medications. Ocrelizumab is typically given on an every 6-month basis. So what they looked at was doing it 9 months versus 6 months, and they really did not show any loss of effectiveness with the 9-month regimen versus the 6-month regimen. Infection risk was lower in the 9-month group than in the 6-month group. Natalizumab, they looked at going from 4 weeks to 6 weeks. Again, no obvious loss of effectiveness. The risk of PML did go down with the 6-week dosing. I think the natalizumab extended interval dosing is interesting in the real world, in that in some people with natalizumab, less so with the B-cell therapies like ocrelizumab or Briumvi. Some of our natalizumab patients clearly have a wearing off effect. They will tell you, as I come close to my next dose, I tell a difference. And we refer to that as the crap gap. So, I think in some people, there may be some challenges going from 4 weeks to 6 weeks if they're already experiencing some wearing off effect at 4 weeks. We do hear some folks on B-cell therapies like ocrelizumab say they have a wearing off effect also. It doesn't seem to be quite as common or as dramatic as what we see with natalizumab. So if the clinical markers that we see with aging tend to change. So whereas early in MS we see relapses, we see new lesions on MRI, and those things seem to go away as we get older, what we tend to see instead is this slow progression of disability. What are the things that we see on MRI if we're not seeing new lesions? Well, we tend to see what we call slowly expanding lesions, or sometimes referred to as chronic active lesions on MRI. And this can be challenging because some of these slowly expanding lesions on MRI can be very subtle, and they're not always easy for the human eye to appreciate. So this then gets into some of our newer technologies. One of the programs that we use at our MS Center, and there are lots of other versions of this out there, is something called quantitative MRI. The program that we use is called IQMS. There are lots of other good programs out there. These programs use some combination of the human eye looking at the MRI plus AI to really put numbers to what we're looking at. So with these programs, we can give a cubic millimeter volume to the number of white spots, the T2 lesions, to new lesions, to enlarging lesions. We can measure whole brain volume. We can measure the volume of white matter. We can measure deep brain gray structures like the thalamus in a way that the human eye just can't do it. And then these things get graphed out, as you can see here, over time. So when you do the first one, these may not have a whole lot of meaning, but as you do, subsequent scans year after year after year, you really can follow people in a very, very sensitive way. So the MRI correlates of progression independent of relapse activity typically are not going to be new lesions on MRI. They're going to be things like brain atrophy, thalamic atrophy, cortical gray matter atrophy, these slowly expanding or chronic active lesions. And then there's another type of lesion called paramagnetic rim lesions or pearls that we see sometimes as people have moved maybe towards a very inflammatory relapsing forms of MS to maybe a more progressive MS characterized by slow progression of disability. And these new quantitative MRI programs are just incredibly helpful at measuring these things. Another test that we can use that might be of help in measuring sort of this slow progression is called OCT, or optical coherence tomography. Let's grab a quick drink here. So OCT uses light waves to measure the thickness of the retinal nerve fiber layer. Your retinal nerve fiber layer is really an extension of the central nervous system, and it correlates directly with brain volume. So loss of the retinal nerve fiber layer has been shown to correlate clinically with PIRA, progression independent of relapse activity. This is what the OCT machine looks like. Very simple, very fast, painless. Takes about 5 minutes to do it. And then it gives you these reports here that sort of look at the retinal nerve fiber layer. What we like to look at, especially, are these little pie graphs here, where it looks at each section of the retinal nerve fiber layer and gives you the thickness of it and color codes it. On this particular machine, green is good. It means you have a normal retinal nerve fiber layer. Yellow and red means the retinal nerve fiber layer is thinning, and that could be a bad thing. So thinning of the retinal nerve fiber layer, whereas it can be something that we use in MS, it's important to note that other things can also thin the retinal nerve fiber layer. So your ophthalmologist, they've been using these machines longer than we have. They use it to follow glaucoma. They can look for it, use it to look for things like retinal detachments, vitreous detachments. But in our world, we're specifically interested in it to follow MS over time. A newer blood test that's available, I think, has been helpful as a biomarker. So Octave is a blood test that looks at 18 biomarkers. These are markers for inflammation in the brain. They're markers for myelin biology, markers to look at what the immune system is doing, markers that look at how intact the axons and neurons are. And this test takes all of those 18 numbers, puts them together, and assigns you something called a multiple sclerosis disease activity score. Low is good, high is bad. Middle of the road, moderate numbers, we don't know quite what to do with yet, and we probably are going to follow those over time. So this Octave test is used in a number of settings in multiple sclerosis. It might be used in someone who's newly diagnosed. If that newly diagnosed individual has very hot disease, a lot of inflammation, a lot of relapses, you would expect their MDAS score to be high. And then the hope is when you put them on treatment that it's going to come down. We use it and with the topic at hand today, in the older individual, maybe the individual who is de-escalating or discontinuing treatment, what I like to do is get a baseline octave score in that individual before we start changing their treatment, or maybe to help decide if we're going to change their treatment or discontinue, de-escalate their treatment, and then follow that over time as we de-escalate or discontinue their treatment. So with that, I am going to stop and turn it over for Q&A, hopefully answers. I know we'll have questions. And Chris, I will kick it to you to open things up.
All right. As you mentioned, we're going to open it up for some questions. Just a reminder, if you have a question or comment, you can ask it using the Q&A button in the app, which allows you to send your question anonymously if you so choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you and then you will be able to unmute and ask your question. For those participating in Zoom, we would like to ask that if you are sending us your questions rather than asking, please avail yourself to the Q&A portion of the application. So we are going to ask, we're going to move on to our very first question. And this is actually a little bit of a long one, so bear with me. This comes from Kathy. I was diagnosed in 2023 at the age of 71. I have 2 doses of Ocrevus, but my MS doctor is reluctant to give me more. I have been stable with my disability symptoms since about 5 months after onset. I did get some return. My MS doctor has agreed to monitor my B cells every 3 months and only give me another dose of Ocrevus if my B cell level rises. I am on no other DMT. What do you think?
So this is an interesting situation. I mean, so I would argue that Kathy, your immune system did not read the textbook. It didn't realize that you shouldn't be diagnosed with MS at 71. But we see this. We see individuals who, whereas the norm is to be diagnosed in your 30s, maybe into the 40s, there are individuals who are diagnosed at much younger ages and at older ages as well. So the idea of using Ocrevus for a couple of doses is not crazy. So the concept is called induction therapy. The idea being I'm going to go in and get this person's MS under control with a highly effective therapy like an Ocrevus, and maybe I can just do a couple of doses and that's it. We are seeing evidence that drugs like Ocrevus, these B cell therapies, may have a much longer lasting immune effect. And so one thought is what she's doing is to monitor the B cells and see when they come back. But I would argue just as importantly, you want to really not just look at the labs, but how the person is doing, because there is some evidence that when the B cells start coming back after doses of these B cell therapies like Ocrevus, that may not mean the person's going to do poorly. There is some evidence that drugs like Ocrevus may change the way B cells function for a long duration. And so I would argue to not just look at the labs, but also really look at how the person's doing. This might be someone where you do the octave or similar blood testing to look for markers for inflammation to kind of go along with what the B cells are doing. So I would say that this scenario it's a little unusual in that it's an older age at onset, but the idea of using Ocrevus for just a very short period of time is perfectly reasonable.
All right. Our next question comes from Karen. Karen, can you hear us?
Yes, I'm here.
Feel free to ask your question.
Thank you. So if you've had many MRIs that have just been looked at by a radiologist, can this new programming like the IQ MS, can I have a disc of these old MRIs and have it read by this software?
Yeah,
Or is
that's a
it
great
the process of the MRI?
Yeah, that's a great question. And unfortunately, the technology cannot be used retroactively. We had the same question when we brought the technology on board here. It's like, oh, great, we can take all of our old MRIs and go back and get reports. Unfortunately, it's only going forwards that you can do this.
So it has to be done live.
It has to be done live. And as people go forwards with this technology, we really encourage people to have their MRIs done on the same scanner, because changing scanners from time to time can actually make the software less reliable. So for instance, here at our center, we have one MRI that's made by GE. We have one MRI that's made by Siemens. We really try as much as possible to make sure the individual with MS is getting their scan done on the same scanner year after year.
And are those 7T?
These are 3Ts that we use. So in theory, you could use this technology on 1.5T, 3T, all the way up to the other scanners. So the strength of the magnetic field really it primarily affects the resolution and sensitivity of your MRI, but you can use the IQMS, NeuroQuant, these other technologies. You can use it on just about any strength magnet.
All right. Thank you so much for your question, and we appreciate it. Now we'll move on to our next. This is coming from Anonymous. Will going from RRMS to SPMS speed up this de-escalation?
So as we age, I mean, and our immune system changes, people with MS can move from relapsing remitting to secondary progressive. So just a little side note, we do divide secondary progressive now up into two types: with activity and without activity. With activity would mean that you are having progression, but you still have new lesions on MRI, enlarging lesions, or relapses. Without activity means that you don't have new lesions on MRI, you don't have relapses. We think that our current disease-modifying therapies probably lose effectiveness as the person moves towards secondary progressive MS without activity. So that would prompt us to maybe think about de-escalating or discontinuing, because maybe there's a point where there's really no benefit from the disease-modifying therapy. We do have a drug coming out likely in late September called tolobrutinib, a very new class of medication. It's in a class of drugs called BTK inhibitors. And this will be the first drug that is FDA approved for secondary progressive MS without activity. We don't have the final word yet on primary progressive MS. So this is going to give us something to add into this discussion. Maybe as some people are de-escalating or discontinuing, if they're seeing ongoing progression of disability, maybe moving towards tolobrutinib is going to be part of this decision process.
All right, just a reminder, if you have a question or comment, you can ask it using the Q&A button in the app, which also allows you to send your question anonymously if you so choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button and press *9 if you're on the phone. I will call on you, and then you will be able to unmute and ask your question. And our next question comes from Tiffany. Give me just a moment here. Tiffany, how are you? Can you hear us?
I can hear you. I'm doing well. How are you?
Doing well. You have a question for us.
Yes, sir. So I am 51 years old, diagnosed in March, took my first Ocrevus infusion in April. My question is, with the de-escalation, and that I'm on a clinical trial, so I know I'll at least get 3 treatments. My question is really about the crap gap. If I decide at some point to quit this, if these B cells are DMTs are not supposed to help you get better, then why would you have the crap gap? Does that make sense?
Yeah, so that's a great question. So we've always preached that the disease-modifying therapies are like your insurance policy for the future. They're designed to prevent future stuff, not make you feel better now. But then we come along with therapies like the B cell therapies and with Tysabri, and some people do feel better on them. I'm not sure that we understand how that works exactly, but it's a real thing. So I think it's important to realize that the crap gap doesn't necessarily mean that your MS is getting worse, though. So I think it's a symptomatic issue. People feel worse, but we've never seen any evidence that the crap gap is associated with new lesions on MRI or progression of disability or relapses. So it's still can be an issue. I mean, I've seen the crap gap in some people be enough that people don't want to mess with their, with changing their regimen. They don't want to de-escalate. Whereas other people, they'll say, yeah, I can push through it and get past this. So yeah, I think that we do have to factor that crap gap into things when we think about de-escalating.
Thank you for your question, Tiffany. We really appreciate it. Our next question comes from Anonymous. How does menopause factor in?
Yeah, so as hormones change in women, probably the most dramatic hormonal fluctuation we see in women with MS would be pregnancy. And so we know that the pregnancy has a overall positive effect in terms of how people feel in the second and third trimester of pregnancy. And then you get a higher risk of relapse for somewhere between 3 and 6 months after the baby's born. The effect of menopause is not as dramatic as the effect of pregnancy, but there is some research to suggest that there might be some potential for progression of disability post-menopause. I think the challenge with that is how do you separate out that menopause effect versus just the normal human aging effect, because we see some risk of progression in older men as well. So I think the practical advice is we don't have any evidence that going on standard hormone replacement therapy has an effect on MS. So if a woman is, perimenopausal, postmenopausal, and she's highly symptomatic, hot flashes, things like that, and needs to go on hormone replacement therapy, we're absolutely fine with it. If she's not having those postmenopausal symptoms and she doesn't want to go on hormone replacement therapy, we're fine with that as well.
All right. Our next question comes from Debbie. Debbie, can you hear us?
Yes, I can.
How are you doing today?
Good. How are you?
Good. It's good to have you with us.
Thank you. Thank you. Yeah. I just wanted to ask if you have any experience with people on Copaxone de-escalating with that particular drug. Like, how would you de-escalate with that medication?
So I would say the majority of our folks that we have taken off of treatment, I would say with Copaxone, it's been more discontinuation than de-escalation. We had a lot of folks that were on platform therapies, Copaxone, Betaseron, Rebif, Avonex. And again, that's where the DISCO MS study had the strongest data. If I have someone on Copaxone and they've been truly stable, they look like that person in the DISCO MS trial, no relapses, no new lesions on MRI. I'm fairly comfortable stopping Copaxone in that person. Now, if someone is very nervous, number one, they don't have to stop. Copaxone is an incredibly low risk drug. It is probably the safest DMT we've ever had. We do sometimes de-escalate. We'll say, well, if you're on 3-time weekly dosing and you're not comfortable stopping, maybe we'll go to twice a week dosing for a while, and then once a week dosing for a while, and just see how you do. The other thing that I factor in is that most people with MS are on vitamin D replacement therapy. 85% of people with MS are vitamin D deficient. I think vitamin D is a disease-modifying therapy. I do think it has a positive effect in the immune system. So we always continue that. So even when someone stops a drug like Copaxone, we're going to continue their vitamin D. So you could argue they're still on a little bit of a disease-modifying therapy.
Very good. And how difficult do you think it's going to be to get the new medication, for the secondary progressive?
So there are a lot of unknowns with that. Yeah. So the honest answer is we don't know. And this is me speculating, what I think will probably happen is that the drug manufacturer might have some mechanism where they're gonna allow access to the medicine even before the drug gets on insurance company formularies. So just because the FDA approves a drug, that doesn't necessarily mean that's exactly when insurance companies start putting it on their formulary and paying for it. So it'd be nice if there was some mechanism to get people on quickly while we're waiting for insurance to do their thing. And I don't know for sure that that's going to happen, but I'm hopeful that it will.
Thank you for your question, Debbie. We really appreciate it. I would like to remind everybody that give me just a second here. I would like to remind everyone that if you have a question or comment, you can ask it using the Q&A button in the app, which also allows you to send your question anonymously, if you so choose. Also, you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you, and then you'll be able to unmute to ask your question. And we move on now to our next question. I have PPMS and 69 years old. My DMT was stopped due to age. Question, should I have stayed on Ocrevus rather than stopping?
So Ocrevus is our only FDA-approved option, our only approved DMT for primary progressive MS. There is a lot of evidence out there that as people with MS age, that there is increasing risk of infections with the B-cell therapies like Ocrevus. So I do think at some point in people with primary progressive MS, as they get older, that is a discussion that needs to be had. We do see a higher risk of upper respiratory infections, UTIs. We learned a big lesson during the Delta surge of the COVID pandemic. When you look at all of the MS disease modifying therapies out there, the class where we saw the highest rate of hospitalizations and deaths during the Delta surge of the COVID pandemic were the B-cell therapies like Ocrevus. So on one hand, they're really effective drugs. On the other hand, we do need to look at that risk-benefit ratio. So I don't think that it's necessarily a mistake that you went off of the Ocrevus as you're getting older.
All right, our next question comes from Lori. I've been on Tysabri since 2006. Works wonderful. Is this too long to be on?
So there's no expiration date on Tysabri. I think early on with Tysabri, when PML popped up and we really didn't have good testing for JC virus, we kind of used 2 years as a rough guideline. But now that we've got JC virus antibody index testing, we can monitor that. There really is not a time limit as long as that JC virus antibody index is staying within the safe range. I mean, we have a gentleman who's been on Tysabri for, approaching 300 infusions, so a very long time. He's probably amongst the longest individuals in the United States. So as long as that safety testing is being done, there's not a time limit.
All right, our next question comes from Josh. Josh, can you hear us? Are you with us, Josh? Let's try that again. Josh, can you hear us?
You scared him away, Chris.
Yeah, unfortunately, Zoom does not appear to be cooperating with us on this one. So until that can get cleared, I move on to our next question. This one comes from Ben. In the realm of older MS patients, why does there seem to be a difference of opinion between medical professionals on stopping a DMT?
So it is a hot topic in the MS world, and I would say there is not. You hit on a great point. There is not uniform consensus in the MS literature and some of our groups, chat groups where we go back and forth with each other. There are arguments about this very topic, and so the data is what it is. And so people, like with the DISCO MS trial, some people have looked at that and said, well, there is a difference between the group that stayed on treatment versus the group that went off. There was a higher risk of relapses. There were more MRI lesions, and the group that would argue for discontinuing would say, but it doesn't look like it mattered. Their disability was no different. So that's because the data is somewhat mixed, and there are different ways that healthcare professionals might interpret that data. I think that's where you're coming from. Personally, I think too, just like individuals living with MS have different levels of risk tolerance, I think healthcare providers have different levels of risk tolerance. And so, the healthcare team's own personal biases and their kind of how they look at things probably factors into this as well.
All right, I'm going to try Josh again here. Josh, can you hear us? All right. I guess there's just
Gremlins.
yes. We are very sorry, Josh. I have another question here. This one comes from Linda. I am 64 on Avonex for 25 plus years. Would a neutralizing antibody test prove if it is still working? I am stable.
So the neutralizing antibody test is really very specifically looking for just that, neutralizing antibodies. The likelihood that someone who's been on Avonex for 25 years would have neutralizing antibodies is really close to zero. Typically, if someone was going to develop neutralizing antibodies to an interferon like Avonex, they usually would do it early on, usually in the first year or so of being on treatment. So that you really can't use that specific blood test to tell, whether it's still working or not. I think you determine, whether your Avonex is working by thinking about what's the goal for any disease modifying therapy. Well, the goal is an acronym called NEDA, N-E-D-A, no evidence of disease activity. So that means no relapse, no progression of disability, no new MRI lesions. You could say, well, it would be great to apply some of these newer technologies if you could have quantitative MRI testing and show that there are no slowly enlarging lesions. You might be someone that, they might think about doing a blood test like the Octave test to make sure that your MS disease activity score was low. But you are exactly the type of person that they looked at in the DISCO MS trial. You would have been eligible for that study. And again, when we looked at how people did in that, there wasn't a huge difference in people like yourself that stayed on versus went off of treatment.
All right, just a reminder, if you have a question or comment, you can ask it using the Q&A button in the app, which also allows you to send your question anonymously if you so choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you, and then you will be able to unmute, hopefully, to ask your question. Our next question comes from Pam. Sorry. MS was incidentally found in an MRI on my, let me try this again. MS was incidentally found in an MRI my ENT ordered for ear tingling. I was 58 years old. I was shocked when they told me 30 lesions were found, yet I've never had any neurological symptoms. A lumbar puncture confirmed MS with 2 different neurologists. I've been on Tecfidera since 2020 and low dose only with no new spots, and I'm still asymptomatic. How likely will my MS evolve at 63 years old being asymptomatic?
So it would be a low likelihood, not zero, but so the MS to a certain degree is almost like a self-fulfilling prophecy. How someone has done over the past few years is to a certain degree predictive of how they're going to do in the future. So if a person has been stable, the odds are that they're likely going to remain stable. That scenario where MRI lesions are detected, so you're looking for one thing, someone has an ENT problem, someone has migraine headaches or a concussion, and they get an MRI and we see changes that look like MS, is referred to as a radiographic isolated syndrome. So we know that MS lesions can appear in the absence of symptoms or before symptoms pop up. So it is a whole, other area of discussion in the MS world. Should we start that person on treatment? Do you observe them? There's no right or wrong answer. And I think some people will err on the side of going ahead and starting treatment. One of the challenges when we do start treatment in someone like this individual is exactly what she's seeing. So the person is stable now, years out on their disease modifying therapy. Are they stable because of the disease modifying therapy, or are they stable because they were going to be stable regardless? And there's no way of really answering that. So I think at some point, this would be an individual where the discussion of de-escalation or discontinuation is probably going to come up.
All right. Our next question is from Danita Brooks. Danita, can you hear us?
Yes, I can. Can you hear me?
Yes, we can. How are you?
Good, thank you. How are you?
I'm doing well. You have a question for us?
Yes, my question is, I was diagnosed with MS in December of 2020, and I will be turning 60 years old the end of this month. I have been stable, besides when I was diagnosed, I have not had any symptoms, and I'm on glatiramer acetate. Um, my question is, I go to the neurologist every 6 months for checkups, but I have only had the one MRI that I had when I was diagnosed. And like I said, I've not had any symptoms since I was diagnosed. So my question is, how important is it when we're talking about discontinuation or de-escalation? How important is it that I try to push having another MRI? Or should I have several before I, I think about discontinuing?
So I think it's important, when we think about the goal for your MS therapy or any MS therapy, again, with this term NEDA, no evidence of disease activity. And so 1/3 of the goal is no new lesions on MRI. So I think it's important in determining, kind of where your MS is at. So if you've gone 5 years and you have an MRI now and it's unchanged from where you were at the time of diagnosis, I'm not sure that you would need bunches of them going forwards to have the discussion about potential de-escalation or discontinuation. If you've been clinically stable and you have a stable MRI now versus 5 years ago, you would kind of meet the definition of what the people looked like in that DISCO MS trial that we discussed.
Thank you for your question, Danita. We really appreciate it. Our next question comes from Anonymous. Is relapse relevant to PPMS? Possibly is used to refer to progression of disability.
So by definition, a person with primary progressive MS really should not have relapses. So that's kind of the definition of primary progressive MS is that it is truly progressive only. Now that said, people with primary progressive MS can have a worsening of symptoms that really is not a true relapse. So if a person with primary progressive MS gets a urinary tract infection or an upper respiratory infection, they're going to have a decline in their level of functioning, but that level of functioning should bounce back once that infection is cleared. So if a person with, has been diagnosed with primary progressive MS, but they're really having true relapses or a lot of new MRI activity, it would make me want to kind of take a step back and say, okay, have I really got the right classification here, or is this really not primary progressive? Is this really a relapsing form of MS?
All right, our next question comes from Linda. Linda, can you hear us? Linda, can you hear us?
Can you hear me?
Yes.
Okay.
How are you this afternoon?
I'm good. Thank you.
Your question.
Hi, Dr. Thrower.
Hey
I
there.
actually saw you in Spokane about 40 years ago.
Oh my gosh.
Yeah. So my question is, I've been off my Tecfidera for about 2 years because I'm 63. And the neurologist suggested that I go off because of age. So this spring, I started a new symptom in my right leg, lower right leg, of a squeezing, jabbing feeling. And so we did a brain, cervical, and thoracic MRI. No new lesions. So they said it wasn't MS related, which I really feel it is. What do you think?
So, anytime people have discomfort, that's the $1,000,000 question. Is it MS or is it something else? And sometimes it's a process of exclusion. So, have you got a better explanation? If testing is appropriate to rule out other causes, if everything else has been ruled out, could MS cause a symptom like that? Yes. And so you can have symptoms like that either from neuropathic pain or sometimes spasticity and spasms, kind of get into that squeezing sort of discomfort realm. So it's certainly possible that this is MS. Let's assume that it is your MS that's causing the discomfort in the leg. that's still not necessarily an indication that your MS is somehow raising its ugly head. So sometimes discomfort like spasticity and spasms or neuropathic pain are due to old MS lesions, not new MS lesions. So it's reassuring that the MRI is stable, but I don't think the stable MRI means that it's not your MS that's doing it.
Thank you for your question, Linda. We really appreciate it. We have time for one more question here, and that is from Janice. Are active biomarker panels available at most labs?
So it would be unlikely that you could just pop in to say, like a LabCorp. Some might do it, but there is some coordination that has to occur between the lab that draws it and then Octave themselves. So for instance, when we set this up at our MS Center, our lab had to sort of get together with the Octave people. So the way it works is whoever's drawing the blood work, they do the initial processing. They put the blood in the centrifuge, they spin it down, and then it has to be shipped off to Octave for them to do the actual the testing itself. So you would for sure want to check with any lab and make sure they have that agreement with Octave, because it's a somewhat unusual blood test, and there's a little bit of coordination that's required.
All right, that brings us to the end of our time today. If you've missed any part of this conference, it has been recorded and will be available through the MS Focus Facebook and YouTube channels. Please reply to your registration email for information on how to access recordings or sign up for our newsletter to learn more about upcoming events. Also, you'll be receiving a short survey when you leave the conference. We'd greatly appreciate your feedback, which helps us determine what type of information is most helpful and meaningful to you. Be with us next time when our teleconference will be on Monday, August 18th at 5:30 p.m. Eastern. Our guest speaker will be Dr. Herb Karpatkin, and he'll be participating in an hour-long Q&A titled Ask the Physical Therapist. We'd like to offer our sincere thanks to all of our attendees for your participation, and especially to Dr. Ben Thrower, who takes time out of his busy schedule each and every month to help educate all of us. Enjoy the rest of your day, everyone, and we'll see you next time.